Welcome back, everybody, to our hospital medicine point-of-care ultrasound curriculum in regards to volume status. This is part 3 of the segment in volume status, and as a reminder, if you visit my website, proceduralist.org, you'll be able to see part 1 and part 2, which preceded this originally. So what have we covered? In part 1, we looked at the inferior vena cava to assess central venous pressure, and then we applied that concept to some volume status in congestive heart failure cases. Today we're going to talk about jugular venous ultrasound as an alternative method for measuring central venous pressure. Coming up in part 4, then we'll apply central venous pressure assessment to several more cases. And finally in part 5, we'll cover shock, which is a fun topic in and of itself. Alright, so let's dive in. So for jugular venous pressure ultrasound, we'll talk about the evidence supporting JVP POCUS. We'll talk about measuring the jugular venous pulsations. This is very similar to the way we do it with our physical exam, and ultrasound just adds an additional level of specificity to this exam. And we'll talk about a few pitfalls to JVP assessment as well to be aware of. So why do JVP ultrasound? Does anyone endorse JVP point-of-care ultrasound? So several groups have come out in recommendations saying this is a good thing that we should teach. For instance, the Canadian Internal Medicine Ultrasound Group said we should teach all of our residents in the country of Canada to do jugular venous pressure ultrasound. Cardiologists have come out in their journals saying, look, if you want to assess right atrial pressure, one way to do that is IVC ultrasound, but we can also use jugular venous pressure ultrasound as well. And finally, the point-of-care ultrasound for hospitalists position statement from the Society of Hospital Medicine, they cite JVP ultrasound as well can be used to assess central venous pressure. It's not talked about as much as inferior vena cava ultrasound just because there's a huge number of IVC ultrasound studies out there, and there's a smaller number of JVP studies, but it is evidence-based. So why and when should we use JVP ultrasound? So you'll remember if we're looking for high central venous pressure, the traditional jugular venous exam, where we just use our eyes to assess for pulsation, has a very high failure rate. When we do IVC ultrasound, the failure rate's much lower, and as a result, our sensitivity for detecting high CVP goes up. But there's still a 10% failure rate in the hands of trained practitioners. So when you do JVP ultrasound, the failure rate hasn't been well documented in the studies, but the sensitivity is really great, even higher than IVC and JVP ultrasound for detecting high central venous pressure. So in other words, when do I do JVP point-of-care ultrasound? Often when I can't find the inferior vena cava. So we said about 10% of the time we really can't find the IVC. So when you can't find the IVC, let's place the probe on the neck and see if we can assess central venous pressure that way. I also use JVP ultrasound with borderline IVC measurements. For instance, if you assess a central venous pressure that's 5 to 10 millimeters of mercury on your IVC assessment, but it's less than 35% collapsible, you'll remember from part 1 of our volume status series, this is the least specific category. A lot of the times, this is an inaccurate measurement when it comes to IVC. For instance, this case is a classic example. Here the IVC is 2.1 centimeters, which puts him at, a normal sized IVC, but it's less than 50% collapse here. It's 26% collapsible. So he ends up in this category of CVP of 5 to 10. But again, because it's so poorly collapsible, a lot of the times this CVP could be much higher than we realize. Especially in a case like this, we measured at 2.1 centimeters. If we moved our marker just 0.1 centimeters, we'd go to 2.2 and we'd be in the max IVC category. So these borderline measurements that are right around 2.0, 2.1, 2.2, or if the collapsibility is borderline like 45%, 55%, kind of in that range, JVP ultrasound can better classify which category we're in, because just a slight change in this measurement of 2.1 centimeters could put us into the high CVP category. So anytime we have an indeterminate CVP in this 5 to 10 range with less than 35% collapse, or borderline measurements like a 2.1 or a 50% collapsibility, I'll often do JVP ultrasound to try to add some specificity to what is the true central venous pressure in these borderline assessments. All right, let's talk a little bit about anatomy. So when we talk about central venous pressure, what we're really measuring is right atrial pressure. We want to see what the intracardiac pressures are of this patient. And previously we've been measuring the inferior vena cava because that high right atrial pressures will translate to a dilated and non-collapsible IVC. But the high right atrial pressures will also translate to the superior vena cava, which will force those pressures up to the jugular vein. And so jugular vein is another way to assess for right atrial or central venous pressure. So how do we do the traditional jugular venous pressure exam? We want to set the bed to a 30 to 45 degree angle. And then at this point, the right atrium is approximately 5 centimeters below the sternal angle. This is the junction of the manubrium and sternum, which you can palpate pretty easily on most patients. And we'll look for neck vein pulsations, and we'll try to see how much fluid is built up into the neck veins, and we measure from the sternal angle. Normal being 2 centimeters or less, elevated JVP being 3 centimeters or more from the sternal angle. So for instance, if a patient has a very high central venous pressure, fluid will push up into the neck and be at this level or higher. And when we see the neck veins, we measure, oh, his neck vein height is 4 centimeters over the sternal angle. When you add 5 centimeters to that to get to the right atrium, so that would be a JVP of 9. Let's talk a little bit more about anatomy, because there's a lot of veins and arteries in the neck to be aware of. Oftentimes, if you can see distended neck veins, it's actually the external jugular vein, which is on top of the sternocleidomastoid. Often what we're truly looking for, though, is the internal jugular vein, which is below the sternocleidomastoid and next to the carotid artery as well. Occasionally, you can also see brachiocephalic vein pulsations here in patients with low central venous pressure, closer to the clavicle. So here's an example of a patient. You see he's got external jugular veins. These very prominent veins here are on top of the sternocleidomastoid. You can see the one head here, one head here. Here's his sternocleidomastoid muscle. The jugular vein is under here, but we can see his external jugular veins appear to have distended neck veins. This appears to be someone with high central venous pressure filling the external jugular veins. And that's a valid measure of jugular venous pressure. But oftentimes we can't see the external jugular and we're looking for the jugular vein. And that's where jugular venous pulsation comes in. You'll recall that the jugular venous pulsations have 2 rises. One we'll call an A wave. You can forget the X and C descents here. For the extent of this talk, we'll talk about A wave, which occurs during atrial contraction, which causes a pulsation of the jugular vein. And then during ventricular filling, you get another rise in the neck veins as well. The hard part is there's also a carotid pulsation during the same time. So you have 3 pulsations in the neck. 2 of them, the jugular venous pulsations, A wave and V wave, and 1 of them, the carotid pulsation. And it can be hard to sort out which one is a carotid pulse and which one's the jugular venous pulse. So oftentimes I'll auscultate for S1 and S2. And the pulsation that occurs with S1 and follows S2 is going to be your neck vein pulsation. And the pulsation in between S1 and S2 is the carotid pulse. But you can see how this gets very confusing trying to time up these 3 different waves with auscultation. And as a result, we can often be inaccurate with our jugular venous assessment. So let's see what this looks like in our traditional neck vein exam. So here, there is no external jugular veins to view. So we really got to look over the sternocleidomastoid and see if we can pick up any pulsations. It's hard to see in the bright light, so they're going to dim it down and see if the shadows can cause the pulsations to become more apparent. So now we can see some pulsations here that look like an A and V wave pulsation. But again, it's difficult to sort out what is carotid, what is venous pulsation. But it looks like the height of his pulsations is somewhere around here. So once you've found the height of the neck vein pulsation, like we said earlier, you want to measure the distance of that height to the sternal angle. Again, it's a prominent bony bump where the manubrium hits the sternum. And at this case, this patient's jugular venous pressure height is here, which is 3.5 centimeters above his sternal angle. So if you add 5 to that to get to the right atrium, we'd say his central venous pressure is 8.5 centimeters of water. And here you can see neck vein pulsations. This is the top of it, above which there are no more pulsations. And this is how they got to an elevated jugular venous pressure assessment. The reason why we're going over this so thoroughly is because we're going to do a very similar assessment and just place the ultrasound here to confirm these neck vein pulsations. All right, let's just review the technique to measure central venous pressure one last time. We're going to set the bed to a 30 to 45 degree angle. I generally remove all the pillows to straighten out the neck so their head's not curled over if possible, and turn the head just slightly. I see a lot of people overturning the head. If you have the patient turn their head 90 degrees, you're going to really activate the sternocleidomastoid, which is going to squish the jugular vein and dampen the pulsations. You want that sternocleidomastoid muscle relaxed so the jugular vein can fully expand and contract without being squished. Then you want to locate the highest point of those pulsations. I'll often place a finger at that highest point here, and I'll palpate the sternum and place a finger on the sternum as well. And I measure the height of that sternal angle to the top of the neck vein pulsations. A couple tricks here. I really recommend getting down to eye level to look at the neck. If you're standing above the patient and your head's up here looking down, it's hard to truly assess what this distance is. I really recommend bending your knees and getting your eye level down to the neck veins and sternum to get a good assessment. And I really encourage people to carry a paper ruler or a skin marking pen that has centimeter markers, because the difference between a 2 centimeter measurement and a 4 centimeter measurement is the difference between normal and elevated central venous pressure. And so I always like to remind myself, what is a centimeter or 2 as I'm trying to eyeball or estimate this. Even if you don't use a ruler every time to measure, look at these skin marking pens or paper rulers, which come with the skin marking pens, to remind yourself what is a normal centimeter measurement. And then whatever the distance you measure here, in this case 2 centimeters, add 5 to that. And so in this case, the jugular venous pressure would be 7 centimeters of water, which is normal. So let's just dive in a little bit in terms of categorizing normal versus elevated central venous pressure. There's been a lot of studies that have looked at this, that have done a physical exam and then done a right heart catheter, a central venous catheter, to measure the right atrial or central venous pressure. And they've determined that normal patients, a normal central jugular venous pressure is 7 centimeters. So when you're over 7 centimeters to 8 centimeters or more, that is considered an elevated central venous pressure. Traditionally, the sensitivity is not great because it's hard to see neck vein pulsations, but the specificity is pretty good, especially in the hands of cardiologists. An important caveat, we've been talking about jugular venous pressure in terms of centimeters of water, and that's not a one-to-one conversion to central venous pressure, which we measure with a right heart cath, which we use millimeters of mercury. For instance, 1 centimeter of water is about 1.36 millimeters of mercury. So previously, when we've been discussing inferior vena cava, we've been talking about millimeters of mercury, saying high central venous pressure is 10 millimeters of mercury or more. And today we're saying high central venous pressure in a jugular vein is 8 centimeters of water or more. So 8 centimeters of water is a high jugular venous pressure. 10 millimeters of mercury is a high central venous pressure on IVC ultrasound or right heart cath, right atrium. Furthermore, you can't just do a one-to-one conversion because JVP tends to underestimate central venous pressure by 3 centimeters. I'm not going to get into why this is, but the take-home message is JVP over 8 centimeters is high central venous pressure, and a IVC over 10 millimeters of mercury is a high central venous pressure. Okay, so now let's add JVP ultrasound to our central venous pressure assessment. So what I use is the linear probe, which is great for superficial structures. We'll place that in a transverse orientation on the jugular vein just on top of the sternocleidomastoid muscle. And in this transverse orientation, you see the short axis view of the jugular vein. Here's our sternocleidomastoid muscle, and here's the carotid down here. There's a couple different techniques for JVP ultrasound that have been reported in the literature. Some people measure size, some people measure surface area, some people measure collapsibility, similar to IVC assessment where we take in size and collapsibility. But the most commonly studied method, and the one that I practice, is called the collapse point. And I think it's very intuitive compared to our standard jugular venous pressure exam. So we're going to talk about finding the collapse point of the internal jugular vein. So how do we do that? So what I recommend is start with your probe transverse orientation over the sternocleidomastoid down by the clavicle. often you'll see a big internal jugular vein that's not collapsible, and it's bigger than the carotid. Then slide your probe up the neck, up the jugular vein. And as you do that, you'll notice the jugular vein gets smaller as you slide. Now the jugular vein is almost the same size as the carotid. It's shrinking in size as we move up the neck. And if you slide a little bit further in this patient up the neck, you'll find that the jugular vein is now smaller and collapsing at this point. So this is how you identify the collapse point. Start at the clavicle and slide up the neck until you find the spot where the internal jugular vein is smaller and preferably collapsing compared to the carotid. It'll often start bigger than the carotid. You slide up, it becomes the same size as the carotid, and finally it'll become smaller than the carotid. And this is the height of the neck vein. This is the top of the volume of fluid being pushed up from the right atrium. You found the top of this fluid column. So here's another real-life assessment of jugular venous pressure ultrasound, starting down here at the clavicle in the transverse view with the linear probe, and sliding up the sternocleidomastoid muscle to figure out where does the jugular vein go from larger than the carotid to smaller than the carotid. So let's take a look at that. So as you slide up, the jugular vein is becoming smaller. You slide back down, it becomes larger. Slide up again to find that collapse point where the jugular vein is smaller. And now we're palpating the sternal angle to figure out where is the probe in relation to this sternal angle. When the jugular vein is smaller than the carotid, where is my probe? And where is the sternal angle in relation to my probe? And we'll take the same measurement we did with traditional jugular venous pressure assessment. So this is an interesting case. From the sternal angle here to the center of my probe, the center of my probe is actually below the sternal angle. And this patient's laying flat. So in other words, we're about 3 centimeters below the sternal angle. So that means his central venous pressure is 2 centimeters of water. We actually subtract the 3 centimeters because we're below the sternal angle in this case. So this patient has a very low central venous pressure. We had to lay him flat to even find the jugular vein distension. So let's talk about this concept briefly. You can adjust the angle of the bed as needed. I told you to usually start around 30 to 45 degree angle for most patients. But in this case, this patient has a very high central venous pressure. So the right atrial pressure is high. It's pushing up not just to the sternal angle, but another 5 centimeters above the sternal angle. So we can't find the collapse point of his jugular vein because it's somewhere under the jaw. If you sit the bed up a little bit higher, the right atrium falls, and that brings the fluid column down. Now we can see his collapse point here is about mid-neck, and with ultrasound we can identify that by raising the head of the bed 60 degrees. And finally, if you sit this patient upright, and a lot of your severe orthopnea patients really have to be at this upright angle, now the jugular venous height falls to the clavicle, but again, his CVP is still 10. His right atrium is down here, 5 centimeters below the sternal angle, and we find his collapse point about 5 centimeters above the sternal angle. So you can leverage the height of the bed in your high central venous pressure patients, sit them up to find the collapse point. Or patients with very low CVP, you can flatten the bed to dump fluid out of the right atrium into the jugular vein. If they have a low CVP, you can lower the angle of the bed. And again, this patient has the same central venous pressure, but changing the angle of the bed moves the fluid column from the jaw to the clavicle. So here's an example of that. Here's a patient who was very hypervolemic. He wanted the bed raised to 90 degrees, felt very uncomfortable lying flat due to orthopnea. And you can see his jugular venous pulsation here at the angle of the jaw. And if you measure from the sternal angle, here's one of those paper rulers. It comes with your skin marking pen kit. These are great rulers to use. His height of his neck vein is about 12 centimeters above his sternal angle. So if you add 5 to that, his central venous pressure is 17 centimeters, way over 8. He has a very high central venous pressure, and we're able to pick that up sitting at a 90-degree angle. And just to confirm, if you place the ultrasound probe over his sternocleidomastoid, you can see how big and dilated this internal jugular vein is. It's absolutely huge compared to the carotid. This is a sign of very high central venous pressure. And as you slide up, you notice the jugular vein does get a little smaller, but it never gets smaller than the carotid. Even as you slide up his neck, it's hard to find a collapse point because his CVP is so high. So in these patients with high central venous pressure, a dilated IJ may not collapse because their CVP is so high. In contrast to a low central venous pressure, here's what you may see. So in this case, if we place our probe just above the clavicle here, a patient with a low central venous pressure, their internal jugular vein may already be fully collapsed. You can see these really nice A and V waves, which tells me it's communicating well with the right atrium because we're seeing an A and V wave pulsation. But the jugular vein is smaller than the carotid. We've already reached the collapse point. So this patient's central venous pressure is at least 5, maybe even lower. Again, if you here, the middle of the probe is at the sternal angle. And so 5 centimeters below that is the right atrium. So his right atrial pressure is 5 centimeters of water because we found the collapse point here at the clavicle at the sternal angle. So let's go over jugular venous pressure point of care ultrasound technique one last time. Highlight a couple key points. We're going to start with our linear probe over the sternocleidomastoid muscle in a transverse orientation at this angle. We start low at the clavicle with light pressure. You want to make sure you're not squishing the IJ and compressing it on accident. And then we're going to slide up the jugular vein, trying to see where the jugular vein goes from dilated or bigger than the carotid to the same size as the carotid. Often you'll start to see A and V wave pulsatility as the jugular venous distension diminishes, and finally slide up until the jugular vein is smaller than the carotid and collapsing. Make sure to measure from the middle of the probe. That's where your jugular vein is, not the top of the probe. You want to measure from the middle of the probe to the sternal angle. Oftentimes, I'll actually take the probe off the neck and place my finger right here at the middle of the probe, and then I'll use my other hand's index finger to palpate the sternal angle and measure from this finger to this finger on the neck. And again, I'll bend my knees and kind of get down on eye level to really assess what is the difference height from this finger to this finger. All right, so a lot of studies have looked at this collapse point technique where we slide up to figure out where the top of the fluid column is. And how does it perform when we're formally measuring central venous pressure? Well, again, in patients that have high central venous pressure over 10 millimeters of mercury, if your collapse point is 8 centimeters or above, it's very sensitive for ruling out CHF, but the specificity is not that great. If you're over 12 centimeters, the sensitivity goes down, but the specificity is amazing. So in other words, I'll often use an 8 centimeter cut point to rule out CHF. If your JVP is 7 centimeters, 6 centimeters, 5 centimeters, anything below 8, you can rule out CHF. And the higher the JVP goes, the more specific it is for CHF. Okay, let's cover a couple pitfalls to think about when measuring jugular venous pressure point of care ultrasound. With the collapse point, often people want to measure in this longitudinal plane because it looks very pretty. So we've been talking about measuring here in the transverse view and sliding, but you can twist the probe 90 degrees and get parallel to the internal jugular vein. And when you do, it can look beautiful, where you see a nice dilated jugular vein, then it starts to taper down and it becomes fully collapsed. So some people will talk about measuring in the longitudinal view, but it's easy to mess up this technique, so I generally don't recommend it. Here's an example that if your probe is not quite parallel, if you're off angle, you're going to cut off the jugular vein here. So you can see it becomes rounded and more cut off because you're off angle and not quite parallel. And it's easy to do this. So the same person, when the probe is off angle, it looks like their jugular vein tapers right here. But once you twist just a little bit, you can see their jugular vein continues up another couple centimeters and you falsely lowered their central venous pressure assessment because you're off angle. That's why I recommend the transverse view will eliminate this issue with rotation, and try to stay transverse and avoid longitudinal if at all possible. Another thing to be aware of is just like the inferior vena cava, the jugular vein will collapse during inspiration. So as you breathe in, you're not only sucking air into the thoracic cavity, you're sucking fluid out of the jugular vein into the thoracic cavity as well. So here in the transverse view, you can see what looks like an IJ collapse, but it's actually just during breathing that it's collapsing. And during expiration, you can see the jugular vein is about the size of the carotid. And here's the same patient in longitudinal view. You see their jugular vein is still distended, but when they breathe in, it collapses. This is not the height of their neck vein. You need to slide higher up to see where does the jugular vein collapse, or at least be smaller than the carotid through the full respiratory cycle. So again, where to measure? You want to measure not where it collapses during inspiration, but where it's smaller and collapsible than the carotid during the full respiratory cycle. So in this case, you're going to slide further up the neck to find where it's collapsed through the full respiratory cycle. Here's another issue that comes up from time to time. What happens if you can't find the collapse or tapering of the IJ? It could be a high central venous pressure like we saw earlier, or it could be a false positive. So let's take a look at this patient. Here you can see the jugular vein is much larger than the carotid. As we slide up, the jugular vein is getting smaller, but it doesn't appear to be smaller than the carotid during the full respiratory cycle. Despite reaching the jaw, we haven't found where the jugular vein becomes smaller than the carotid. They're about the same size at this point. So we haven't truly found that collapse or taper point yet. And in this patient, when we actually looked at their IVC ultrasound, it turns out they had a very low central venous pressure. They had a small IVC at 1.6 centimeters that was very collapsible at 60%. So this was a false positive. It looked like, quote unquote, the jugular vein had not tapered for 10 centimeters or so, and it looked like a high central venous pressure, but it was actually a false positive. And their inferior vena cava told us, look, this guy has low or normal central venous pressure. So what can cause these false positives or lack of jugular venous collapse? So it could be high central venous pressure, but often what I see is stenosis, that there's something in the jugular vein separating the right atrium from the jugular vein that's not allowing the right atrial pressures to translate up here. This happens all the time with patients with chronic hemodialysis catheters. When they're banging around in the jugular vein, they often cause stenosis. And not full blockage, but enough stenosis that the right atrial pressure does not fully translate up here. And that stenosis causes the jugular vein to dilate above. Or pacemaker wires can cause a similar phenomenon. Or DVTs. If you have a clot somewhere between your right atrium and your jugular vein, that's going to prevent the central venous pressure from translating up to our jugular venous assessment. So what should we do if we can't find a jugular vein collapse? The first thing I do is raise the head of the bed. That's when if they have a high central venous pressure and you raise the head of the bed, you should be able to drop the right atrium down, and that will drop the fluid column down potentially and allow you to measure a collapse. So get the bed all the way up to 90 degrees if you have to see if you can find that tapering and collapse point. I usually perform compression ultrasound to rule out DVT as well. And then if I'm still confused, just check the left jugular vein. We've been talking about measuring the right internal jugular vein this whole time because it's a more direct path to the right atrium. But you can also measure the left jugular vein if you're concerned about a false positive, especially if there's a dialysis catheter in the right jugular vein. You may check the left side and see something very different and more accurate. So here's a case of a deep vein thrombosis. Here's the carotid. Here's the jugular vein. There was no pulsatility in this jugular vein. And here you can see there's squishing, squish, 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 squish. And this jugular vein isn't collapsing. That's a thrombus. You can try color as well, where you see that there's an arterial pulsation and no flow in the jugular vein, which also helps confirm deep DVT. But compression's the real tool. You should be able to squish any jugular vein, and if you can't, that's a clot. All right, so let's just summarize this JVP point-of-care ultrasound curriculum. So when do I do JVP point-of-care ultrasound? If I can't find the IVC, that's a no-brainer. Let's go look at the neck veins to clarify central venous pressure. But I'll also do it for those borderline IVC measurements that are around 2.1 centimeters or around 50% collapse. I'd like to make sure I'm categorizing their central venous pressure in the right box. And so JVP can really help you assess, is this normal or high central venous pressure in those borderline measurements. A couple tips with technique. I really think if you get a ruler, again, they come with those skin marking pens or surgical marking pens that we often use. Take a look at that from time to time right before you're doing your JVP assessment, just to remind yourself, what is 1 centimeter? Because the difference between a 2 centimeter measurement and a 4 centimeter measurement is the difference of normal or elevated central venous pressure, and it's really small. It's just in less than an inch or so. And then when we're looking for collapse point with the jugular venous pressure ultrasound assessment, if you have a JVP that's under 8 centimeters, that's very sensitive for ruling out CHF. And if you have a JVP over 12 centimeters, that's very specific for CHF. In between, it's a little tougher to sort out, and you'll have to use some of your other clinical tools to put that together. And a couple pitfalls to be reminded of: we do want to avoid measuring the JVP during inspiration. You want to see the jugular vein smaller than the carotid during the full respiratory cycle. And you really got to find that collapse point. And if you can't find it, we talked about some troubleshooting techniques like raising the head of the bed, checking the other jugular vein, and finally ruling out DVT if anything looks weird. And the easiest way to do that is just squish the vein. And if you can squish the neck vein all the way, there's no DVT. All right, good work. That concludes this section on jugular venous point of care ultrasound. Next, we're going to go over a few cases in the next segment to kind of hammer in some of these points and go through some great clinical scenarios. And again, you can find that at my website at proceduralist.org. And with that, thank you again.